Coronary artery disease, CAD, remains the single largest killer of Americans, accounting for almost 500,000 deaths per year. It imposes a particular burden on the elderly, with more than 80% of all coronary artery disease deaths occurring in those over age 65. The magnitude of this impact takes on great significance because it is expected that the number of Americans who are older than 65 years of age will more than double over the next 4 decades. If you add to this aging population the anticipated increase in the prevalence of important risk factors for coronary artery disease such as obesity and diabetes mellitus, DM, the population at risk for CAD can only be expected to increase every year. Myocardial revascularization represents an effective treatment strategy shown to prolong survival of the patients. Techniques of revascularization include percutaneous coronary intervention, PCI, and coronary artery bypass grafting, CABG, surgery, which can be performed with or without cardiopulmonary bypass, extracorporeal circulation. Current surgical techniques for CABG can be carried out with low perioperative mortality and morbidity, with excellent long-term outcomes despite an increasing risk profile. CABG surgery with cardiopulmonary bypass remains the golden standard by which the other techniques, i.e., PCI, off-pump CABG, robotic CABG, hybrid revascularization, are measured. It is expected that it will continue to be a cornerstone in the management of CAD in the foreseeable future. Indications for surgical coronary revascularization. The practicing cardiac surgeon is confronted with no clinical question more often than, is coronary bypass indicated in this patient? In brief, the indications established by the American College of Cardiology Foundation and the American Heart Association, ACCF, AHA. Consensus panel are based predominantly on the results of trials comparing surgical revascularization with medical therapy for patients with chronic stable angina. 3 major historical trials demonstrated the greatest survival benefit of revascularization to be among those patients at highest risk of death from the disease itself as defined by the severity of angina and/or ischemia, the number of diseased vessels, and the presence of left ventricular dysfunction. Even as the technology and methods for all manner of revascularization strategies improve, the principles established by these seminal trials continue to serve as the basis upon which the results of newer trials designed to study specific populations, clinical scenarios, and anatomic patterns of disease are compared and interpreted. Clinical and laboratory assessment of coronary artery disease. A surgeon's first introduction to a patient with CAD is frequently a conventional coronary angiogram. Indeed, most studies of coronary revascularization have stratified risk and grouped patients according to the number and distribution of coronary lesions. For the purposes of this discussion, and in an effort to be consistent with the large body of literature upon which the current ACCF, AHA guidelines are based, significant stenosis is defined as is greater than or equal to 70% reduction in luminal diameter of a coronary artery other than the left main coronary artery, LMCA, for which is greater than or equal to 50% reduction is considered significant. A major development in the last decade in assessing the severity of coronary disease has been the introduction of the syntax score, which is a pure angiographic score of severity and complexity that has recently been validated to correlate with 3-year outcomes in patients with triple vessel and/or main stem disease. It uses dedicated computer software to assign points to each lesion based on length, degree of stenosis, and relation to areas of bifurcation, trifurcation, such that the higher the overall score, the more complex the coronary disease. Although the anatomic distribution and severity of hemodynamically significant coronary lesions determines, in large part, the optimal therapy, CABG, PCI, or medical therapy, the clinical presentation and results of non-invasive studies of myocardial perfusion and function are necessary to characterize the pathophysiologic implications of the angiographic disease and its impact on prognosis and, therefore, to make a clinically appropriate recommendation. In the technological era in which we practice, the importance of the clinical history bears emphasis, particularly in an aging population. Because one of the objectives of surgery is to improve symptoms and quality of life, a thorough appreciation of the patient's functional status is a prerequisite in selecting the optimal therapeutic strategy. Furthermore, there may be a strikingly poor correlation between the severity of symptoms and the magnitude of ischemia, as is notoriously the case among diabetic patients with asymptomatic, silent ischemia. Electrocardiography, ECG, if abnormal, is helpful in assessing ischemic burden. Unfortunately, it demonstrates no pathognomonic signs in half of patients with chronic stable angina. Still, the monitoring of an ECG under stress conditions is simple and inexpensive, and is therefore useful as a screening examination. Among patients with anatomically defined disease, stress ECG provides additional information about the severity of ischemia and the prognosis of the disease. The sensitivity of the test increases with age, with the severity of the patient's disease, and with the magnitude of observed street segment shift. If street segment depression is greater than 1 mm, stress ECG has a predictive value of 90%, whereas a 2 mm shift with accompanying angina is virtually diagnostic. Early onset of saint segment depression and prolonged depression after the discontinuation of exercise are strongly associated with significant multivessel disease. Unfortunately, many patients cannot achieve their target heart rates owing to beta blockade or a limitation to their exercise tolerance caused by coexisting disease, decreasing the usefulness of this test in these often high-risk patients. Resting abnormalities in the ECG may also limit the predictive accuracy of the test. Perfusion imaging with thallium-201 or a technetium 99 m based tracer may be particularly useful in patients with abnormalities on their baseline ECG. Reversible defects demonstrated by comparison of images obtained after injection of the tracer at peak stress with rest images is indicative of ischemia, and hence viability and irreversible defect indicates a non-viable scar. For patients unable to exercise, pharmacologic vasodilators such as adenosine or dipyridamole may be used with similar sensitivity. Echocardiographic imaging during exercise or pharmacologic stress has gained increasing popularity among cardiologists. Comparative studies have demonstrated accuracy similar to that of nuclear studies with sensitivity and specificity both around 85%. Patients unable to exercise may be stressed with high-dose dipyridamole, or more commonly dobutamine at doses from 5 to 40 micrograms per kilogram per minute. An initial augmentation of contractility of the heart followed by loss or drop out is diagnostic of ischemia, and accordingly viability, whereas failure to augment contractility at low dose suggests scar. Additionally, information regarding concomitant valvular disease may be obtained during the examination. Guidelines for revascularization. In any discussion regarding the discrete indications for coronary revascularization, it is critical to bear in mind that the overarching goal of revascularization is to either improve symptoms, prolong survival, or, inasmuch as is inextricably tied to both of these goals, to delay and prevent the complications of coronary disease in order to provide improved quality of life over the period of prolonged survival. With this fundamental principle in mind, the guidelines for surgical revascularization established by the ACCF, AHA were significantly revised in terms of organizational structure in 2011 to reflect this understanding. These guidelines outline the recommendations regarding whether revascularization is indicated by either CABG or PCI in comparison to medical therapy in specific subsets of patients grouped primarily by the goal of revascularization, either improvement of survival or improvement of symptoms. Indications are then only secondarily stratified by the anatomic pattern and severity of coronary lesions, taking into account the number of involved vessels, involvement of the LMCA, the proximal left anterior descending artery, LAD. Only after these two distinctions are made are the effects of baseline clinical scenario, e.g., presence of diabetes, severity of left ventricular dysfunction, presence of unstable angina, non-street elevation and saint elevation myocardial infarction, MI, and the calculated operative mortality, among others, taken into account to determine the recommendations for specific situations. The basis for these guidelines resides in the large body of literature comparing medical therapy with CABG and PCI in patients with stable angina pectoris. Recommendations are categorized into classes whereby Class 1 denotes that the benefit exceeds the risk and the procedure treatment should be performed. Class IIA denotes that the benefit likely exceeds the risk and that it is reasonable to administer the treatment. Class IIB may be equivalent to or exceed the risk, but additional studies are necessary to confirm, and that the treatment may be considered. Finally, Class 3 represents a recommendation to not perform the procedure or treatment as it is known to have no benefit and in some cases can be harmful. Each recommendation is paired with a descriptions of the strength of evidences available to support the recommendation, and ranges from Level A, denoting data derived from multiple randomized controlled trials or meta-analyses, Level B, which denotes data from a single randomized trial or non-randomized studies, and Level C, which represents data from just consensus opinions from case studies, experts and previously established standards of healthcare. The complexity of the guidelines reflects the overall complexity and heterogeneity of the patient population presenting with coronary artery disease.